What's going on, you lot? Welcome back to the Jeffrey Talks YouTube channel. This week I am going to be discussing one of my disabilities, Soto syndrome, so let's begin. Soto syndrome is a genetic disorder, described in 1964, characterized by excessive growth before and after birth, a large, elongated head, distinctive facial configuration, and a non-progressive neurological disorder with intellectual disability. Advanced bone age is present in approximately 75 to 85% of patients. The main clinical finding is prenatal and postnatal overgrowth. The growth velocity is particularly excessive in the first 3 to 4 years of life and subsequently proceeds at the normal rate, but in the high percentiles. The mean height is usually 2 to 3 years ahead of peers during childhood. The weight is usually appropriate for the height, and the bone age is advanced mean by 2 to 4 years over chronological age, during childhood. Adult height usually exceeds the average of normal men or women. Some individuals may reach excessive adult heights, males of 193 centimeters to 203 centimeters, 6 feet 4 inches to 6 feet 8 inches, and females up to 188 centimeters, 6 feet 2 inches, are known. The craniofacial configuration is most characteristic, with a prominent forehead and receding forehead hairline in 96% of patients, dolichocephalic head, widely spaced eyes, down slanting of the eyelids and folds, high narrow palate, pointed chin, a long narrow face, and a head shape that is similar to an inverted pear. The typical facial features are most apparent in childhood. As the child matures, the chin becomes more prominent and square in shape. In adults, the craniofacial characteristics are less distinctive, but the chin is prominent and the dolichocephalic and receding hairline remain. Central nervous system manifestations are frequent. Delay in the attainment of milestones of development, walking and talking, and in particular speech, is almost always present, and clumsiness is frequent, 60 to 80%, as is low muscle tone, hypotonia, and lax joints. Intellectual disability is present in 80 to 85% of the patients, with an average IQ of 72 and a range from 40 to borderline mild intellectual disability. 15 to 20% may have normal intelligence. Seizures may occur in 30% of those affected. Some brain abnormalities, enlarged ventricles, may occur. Individuals with Soto syndrome can also experience behavioral problems at all ages that can make it difficult for them to develop relationships with others. Newborns often have jaundice, difficulty feeding, and low muscle tone, hypotonia. Heart defects are present in about 8 to 35% of children with Soto syndrome, but are usually not severe. Abnormalities in the genital and/or urinary systems occur in about 20% of affected individuals. Other findings associated with Soto syndrome include conductive hearing loss that may be associated with an increased frequency of upper respiratory infections, eye abnormalities such as crossed eyes, strabismus, and skeletal problems. A curved spine, scoliosis, is present in about 40% of those affected, but is usually not severe enough to require bracing or surgery. Premature eruption of teeth occurs in 60 to 80%. Approximately 2.2 to 3.9% of patients develop tumors including sacrococcygeal teratoma, neuroblastoma, prasacral ganglioma, and acute lymphoblastic leukemia. Affected infants and children usually experience a delay in achieving certain developmental milestones, e.g., sitting, crawling, walking, etc. They may not begin to walk until approximately 15 to 17 months of age. Affected children may also experience difficulty performing certain tasks requiring coordination, such as riding a bicycle or playing sports, fine motor skills, e.g., the ability to grasp small objects, and may demonstrate unusual clumsiness. Children with this disorder typically experience delays in attaining language skills. In many cases, affected children may not begin to speak until approximately 2 to 3 years of age. Soto syndrome is caused by mutations, abnormalities, in THEA-NSD1A, nuclear receptor binding set domain protein 1, gene. Mutations in this gene have been identified in approximately 90% of affected patients. Soto syndrome 1. A few years ago, mutations in Thea and physogene, nuclear factor I, X type, were identified in 5 patients with Soto syndrome, Soto syndrome 2. In 2015, a loss-of-function mutation in Thea APC2A, adenomatous polyposis coli 2, gene was reported in 2 siblings with some neural features of Soto syndrome including intellectual disability, abnormal brain structure, and typical facial features, but no other features such as bone or heart abnormalities. Soto syndrome 3. The parents were blood relatives, consanguineous. Thea APC2A gene is specifically expressed in the nervous system, and is a crucial downstream gene of NSD1. In other words, mutations in Thea NSD1A gene affects Thea APC2A gene and results in the neural abnormalities. Soto syndrome is an autosomal dominant genetic condition. Dominant genetic disorders occur when only a single copy of an abnormal variant of a gene is necessary to cause a particular disease. The abnormal variant gene can be inherited from either parent or can be the result of a mutated, changed, gene in the affected individual. The risk of passing the abnormal variant gene from an affected parent to an offspring is 50% for each pregnancy. The risk is the same for males and females. Most people with Soto syndrome have Thea NSD1A mutation as the result of a new mutation that was not inherited from a parent. When the parents are unaffected, the risk of having another child with the syndrome is very low, 1%. The symptoms of Soto syndrome can vary from person to person, even when they have the same Thea NSD1A gene mutation. Soto syndrome 3 is an autosomal recessive condition. Recessive genetic disorders occur when an individual inherits an abnormal variant of a gene from each parent. If an individual receives one normal gene and one abnormal variant gene for the disease, the person will be a carrier for the disease, but usually will not show symptoms. The risk for 2 carrier parents to both pass the abnormal variant gene and, therefore, have an affected child is 25% with each pregnancy. The risk to have a child who is a carrier, like the parents, is 50% with each pregnancy. The chance for a child to receive normal genes from both parents is 25%. The risk is the same for males and females. Soto syndrome affects males and females in equal numbers, occurs in all ethnic groups and has been detected throughout the world. This condition occurs in about 1 in 14,000 live births. Symptoms of the following disorders may be similar to those of Soto syndrome. Comparisons may be useful for a differential diagnosis. Confirmation of any of the syndromes can be obtained by genetic testing. Weaver syndrome, also known as Weaver-Smith syndrome, is an extremely rare disorder characterized by accelerated growth. Affected individuals have a particular facial appearance that is similar to Soto syndrome in that a high broad forehead is often present, but the face is usually round in shape, not elongated, with widely spaced eyes, ocular hypertelorism, and an abnormally small jaw. Children often have increased muscle tone, hypertonia, and joint problems. The cause is now known to be a mutation in the EXH2 gene. For more information on this disorder, choose A. Weaver as your search term in the rare disease database. Beckwith-Wiedemann syndrome is a rare inherited disorder characterized by overgrowth, an abnormally large tongue, macroglossia, abnormal creases on the earlobes, protrusion of part of the intestines through an abnormal opening in the muscular abdominal wall near the umbilical cord, omphalocele, and abnormal enlargement of certain abdominal organs, visceromegaly, such as the liver, kidney, and/or pancreas, and hypoglycemia, low blood glucose, early in life. Most individuals with Beckwith-Wiedemann syndrome have an abnormality in one of several genes located on the number 11 chromosome. Molecular genetic testing can help to determine the proper treatment for these patients. For more information on this disorder, choose A. Beckwith-Wiedemann as your search term in the rare disease database. Simpson dysmorphia syndrome, also known as Simpson-Golabie-Bimel syndrome, is an X-linked recessive genetic disorder characterized by overgrowth before and after birth, a particular facial appearance that is different from Soto syndrome, extra fingers and toes, extra nipples, separation of muscles in the abdominal wall, diastasis recti, and a skeletal abnormality in which the chest bone is depressed, pectus excavatum. This syndrome results from abnormalities, mutations or microdeletions, of one of two genes on chromosomes X. For more information on this disorder, choose A. Simpson dysmorphia as your search term in the rare disease database. Fragile X syndrome is a genetic disorder caused by an abnormality in a gene on the X chromosome, with more severe symptoms in males and is characterized by intellectual disability, language delays, behavioral problems, autism or autistic-like behavior, including poor eye contact and hand flapping, enlarged external genitalia, macroorchidism, large or prominent ears, hyperactivity, delayed motor development and or poor sensory skills. Affected individuals may also have an abnormally increased growth rate before puberty. Molecular genetic testing can differentiate Fragile X syndrome from Soto syndrome. For more information on this disorder, choose A. Fragile XA as your search term in the rare disease database. There is no biochemical marker for the disease. The diagnosis is based on clinical grounds. The most characteristic manifestations are the craniofacial configuration, excessive growth, and developmental delay. The diagnosis of a patient with the typical craniofacial configuration and excessive growth can be made at the first sight. The craniofacial configuration is the most distinctive, and only rarely, 1%, is not present. 10% of the children and adolescents may be below +2 SD in height and 10 or 15% of the patients may not have developmental delay. Advanced bone age may be present in 76 to 86% of the patients and is helpful but not specific. Brain abnormalities are present in 60 to 80% of patients, such as communicating hydrocephalus, and others, but are not diagnostic and are nonspecific. The diagnosis can be confirmed by DNA studies by FISH, fluorescence in situ hybridization, analysis to detect microdeletions or MLPA, multiplex ligation-dependent probe amplification, a simple and reliable method to detect chromosome 5q35 microdeletions and partial NSD1A gene deletions, which account for approximately 10 to 15% of the cases in Western populations. DNA analysis by genome sequencing can determine the specific NSD1A gene mutations. In patients without NSD1A gene mutations, genetic testing for mutations INA and FISA and APC2A genes should be obtained. The treatment of Soto syndrome is directed toward the specific symptoms that are apparent in each individual. Treatment may require the coordinated efforts of a team of specialists. Pediatricians, pediatric endocrinologists, geneticists, neurologists, surgeons, speech pathologists, specialists who diagnose and treat skeletal disorders, orthopedists, physicians who diagnose and treat eye disorders, ophthalmologists, physical therapists, and or other healthcare professionals may need to systematically and comprehensively plan an affected child's treatment. When a child is diagnosed with Soto syndrome, a heart examination and kidney ultrasound should be performed, and if abnormalities are identified, an appropriate specialist should be consulted. Children with Soto syndrome should have a thorough examination every 1 to 2 years that includes a back exam for scoliosis, eye exam, blood pressure measurement, and a speech and language evaluation. Appropriate specialists should be consulted as needed. Clinical evaluation should be conducted early in development and on a continuing basis to help confirm the presence and extent of developmental delay, psychomotor delay, and or intellectual disability. Such evaluation and early intervention may help ensure that appropriate steps are taken to help affected individuals reach their highest potential. Special services that may be beneficial to affected children may include infant stimulation, special education, special social support, physical therapy, occupational therapy, speech therapy, and adaptive physical education. A small percentage, 2.2 to 3.9%, of individuals with Soto syndrome may be more prone to developing certain benign tumors and malignancies than the general population. Owing to the low risk for these problems, that the age of onset or detection is from infancy to adulthood and the location variable, 1/3 intra-abdominal, 2/3 extra-abdominal, there is no recommended routine screening. Genetic counseling is recommended for affected individuals and their families. That just about ends this video. Thank you so much for watching, and I do hope you have found it interesting. If you did, please subscribe, and until next week, thank you so much for watching. Stay safe and try and have a good week.